Thank you for having me here. So this is the first time I've ever been to a dental conference ever in my whole life. And I'm glad Alison's left the room, because I would also say I'm a little bit scared of the dentists. You're all quite scary people. So I can understand why people who have bleeding disorders are scared to come to you, and also why you're scared sometimes to treat them, because it's all a bit weird, isn't it? So I've got two talks. The first one is talking about von Willebrands, and I've got disease here because that is still mostly how the medical community, so in this talk I'm being a medic, the medical community talk about von Willebrands disease. And I don't know why, because we don't say haemophilia disease, we say haemophilia or factor 13 deficiency. So the first part of my talk will be about diagnosing and managing von Willebrands disease and your role in that, if we can find one for you. So I'm trying to be a little bit controversial in some of the slides. So von Willebrands disorder is the most common of the inherited bleeding disorders, and about 1% of the population might have it. So you will have come across somebody definitely that you have treated already who will have von Willebrands disease. And unlike haemophilia, it affects males, females, boys, girls equally. So you'll come across women. And in the medical world at the moment, there's a disproportionate focus on women because of heavy menstrual bleeding. And so we're going to try to not focus on that and to focus on the other bleeding that these people have. So von Willebrands disorder is a defect in the concentration or the structure of von Willebrand factor, which is a protein which is in your blood. And that can either be a quantitative deficiency, so you haven't got enough of it, or a qualitative deficiency, so you've got lots of it, it just doesn't work properly. And these are inherited conditions. So you will see whole families who have von Willebrands. There's also something called acquired von Willebrands, used to be disease, is now called acquired von Willebrands syndrome, which is where you acquire von Willebrands disease at some stage later in your life. And that is often associated with autoimmune disorders and lymphoproliferative disease. But particularly if any of you are paediatric dentists, it's associated with Wilms tumour. So the tumours are expressing a protein that the von Willebrand factor sticks onto, so it all gets gobbled up, so it looks like you haven't got any, and then you can have bleeding. And the way to treat that kind of von Willebrand's disease is to treat the underlying condition and not to treat the von Willebrand's disorder as we would for everybody else. So back to von Willebrand factor, it's an adhesive plasma glycoprotein and it binds to factor 8. So factor 8 is what you don't have if you've got haemophilia A, and it's one of the most important proteins in making your blood clot. So von Willebrand factor it's a very long protein and it's all curled up, and then when you have bleeding it sticks to the site of the injury and it stretches out and grabs onto platelets and it drags the platelets down to where the injury is. At the same time as that, it's sticking to factor 8 and bringing it all together to make that really strong platelet plug and to stop people from bleeding. So it's really important in that primary hemostasis. If you don't have von Willebrand factor or it doesn't work, you don't get that instant stopping of bleeding that the factors can then stick onto to make you stop bleeding in longer term. For a medic, you would think it might be quite easy to diagnose von Willebrand's disease, and the next few slides will show you why it isn't. So there are lots of things that make it difficult for us to say this person does or does not have von Willebrand's. So the first is your blood group. So we know that people with blood group O have very different levels to people with blood group A and B. And so you can't just measure the level in the laboratory. You have to look at the blood group and think, well, is this a blood group effect or is this actually von Willebrand's? There's some evidence that ethnicity might be a modifier. And then there are lots of things that we do to people that make their levels go up. So if you've been sitting for 4 hours waiting to get your blood taken, or your child has been running up and down waiting to have their bloods taken, that stress and exercise is enough to change the levels. We just get you to run up and down the stairs. That will change the levels. If you're pregnant, the levels will go up. Depending on where you are in your menstrual cycle, your levels will go up or down, whether you're taking the pill, whether you have thyroid disease, and how good we are at sticking a needle into your vein. So if we're rubbish at doing that, that causes some local activation of your clotting and then can affect the results. So this is not an easy diagnosis by any means. Further complicated by, as I said at the beginning, it's inherited, but this condition is inherited in different ways. So you can have autosomal dominant inheritance, where either your mum or your dad have got it, and then each time they have a child, there's a 50% chance that they will pass on von Willebrand's disease to their child. So it could be a boy, it could be a girl, it could be a mother, it could be a father. So you might have bleeding. Also within this, there's something called variable penetrance. So I might have a level of 20, and I might pass this on to my child, my son, say, who might then have a level of 49. So that doesn't mean he doesn't have it. It's just that my variable penetrance has gone through the family in a different way. The easiest kind of von Willebrand's to diagnose is the most severe, which is called type 3. And that is where you have an almost absence of factor VIII and von Willebrand factor. And to get that, you are inheriting in an autosomal recessive manner. So your mum and your dad will both be type 1, as we call them, von Willebrand's, and they might or might not bleed. And then you end up with a child who has very severe bleeding, like a boy with severe haemophilia would, but this might be a girl, remember that. And they present differently. So they might present with mouth bleeding rather than a boy with haemophilia, who would much more likely present with a joint bleed. So I've been a haemophilia nurse for, well, 30 years, quite a long time. I obviously started when I was very, very young. And not really very much changed in all of those years. So getting the diagnosis right was difficult. There's lots of subtypes, which I'll show you in a couple of slides' time. And really, there was no consensus on exactly what was what. Everybody was doing things slightly differently. So in 2021, two new guidelines were published. The first was this one, which is about diagnosing von Willebrand's disease, because this is doctors writing this, remember? So even though very modern, it's still called disease. And this is a collaboration between the American Society of Haematology, the International Society of Thrombosis and Haemostasis, the National Haemophilia Foundation, and the World Federation of Haemophilia. So lots and lots of very clever, eminent doctors and scientists. And they've come up with this algorithm for how we diagnose von Willebrand's disease. Now, I know you probably can't see this, but right at the very top up here, we've got a patient who's been suspected. And then we have to do a bleeding assessment tool. And that asks things like how much bruising you have, whether you've had bleeding after surgery, whether you have heavy periods, whether you've ever had a joint bleed, whether anybody in your family has. There is very, very, very little stroke nothing about dental mouth bleeding, unless you are talking to the parents of a 1-year-old who's just presented with a mouth bleed. Based on the results of that, we then either go down the we don't think you've got anything wrong with you route, or we go down this route over here, doing all of these different tests at different times to come up with a diagnosis of what kind of von Willebrand's disease you've got. And you can see here that these are all the types and the subtypes, which are of no relevance at all to anybody in this room, or really to people who have von Willebrand's. Because what they need to know is, how do I get treated? How do you treat my bleeding? How do you stop my bleeding? And is there something I can do that is prophylaxis? So the people who have the worst bleeding will be given factor VIII or von Willebrand containing factor, so a plasma-derived product, to either as prophylaxis, so like a person with haemophilia would, so they might get it 2 or 3 times a week, or they will have treatment that they can give at home when they're going to do something that is risky. So if they're coming to the dentist, they'd be able to treat themselves at home before they come. Some of them, though, don't need that level of replacement of von Willebrand factor or of the factor VIII, and they can be treated with some other products, which I'll talk about in a minute. As Alison said earlier, there's very little data really that talks about how much people with von Willebrand's bleed. So when they come to clinic, it's kind of a bit of a tick box exercise. So have you had any bleeding? Yes. Where from? Periods. Okay. What are we going to do about that? Have you got bruising? Yes. For children, does the bruising look suspicious beyond it being von Willebrand's disease? And then there's usually a tick box question about, are you seeing the dentist? So I would say, do you see the dentist? Yes, tick. But we don't really then talk about why are you seeing the dentist? What is the dentist doing to you? Are you seeing the dentist because of bleeding, or are you just going every 6 months for a routine checkup? So we're not good at talking about how important the dentist is. And this study here from America, and I couldn't find any European data, but this is American data, shows on a pharma database for commercially insured patients that the talk is all about heavy menstrual bleeding and epistaxis. And there is no mention at all in these 3,500 patients of oral bleeding. I don't think that can be true. I think if you went out onto the streets and asked 3,500 people if they ever bled from their gums, they would, at least some of them would say yes. Interestingly, if you look at the US Haemophilia Treatment Network data, so these are the same kinds of patients in America. This is people going into the centres to be treated. 32% of them present the first bleed is from the oral mucosa. And you can see that that is happening in very young children. So this is not about having gingivitis, because we haven't got that far down the right road yet. So this is children putting things in their mouth, as children always do. It's frenulum bleeds, it's bleeding with teeth coming through, and trauma. If we're not addressing it at this age and we're saying it's okay, it's just von Willebrands bleeding, then of course they're going to go on to develop gum bleeds that you guys have problems treating when they've got bad gingivitis later on. So we need to be much better at bringing dentistry into the care that the patients have. So our treatment options, again, designed by those same group of big international people on how we treat people with von Willebrands disease. So I'm glad Luciana's in the audience, because there are great treatment guidance from the WFH on haemophilia. There's a massive tome of everything, all about haemophilia. It's not about von Willebrands disease, and we need to be sure that what we're implementing for that group that have haemophilia is also goes across into the other bleeding disorders, and we'll talk a little bit more about that later on. So their recommendation, this is a really good one, you wouldn't have thought of this yourselves, was that you might consider the use of local hemostatic measures, such as using a gelatin sponge or some fibrin glue or some tranexamic acid as part of a treatment plan. That's all they say about dentistry. Shocking, isn't it? Really shocking. So clearly all of those people that have written all of those guidelines on how we treat people with von Willebrands are concentrated on heavy menstrual periods, bleeding from the GI tract, bruising, and not on people's mouths. And as Alison said earlier, people's mouths have a huge impact on them psychologically. And here is a question that was put to Alison at one of those EHC meetings that we were at recently. So what percentage of people with von Willebrands report problems of oral bleeding? And Alison said, basically, we don't know, because using the BAT score, like I said earlier, doesn't really talk about dental bleeding or mouth bleeding unless it's that you've had a tooth out. But we know from those patient surveys that there's lots of bleeding from the gums. That often follows brushing, and so therefore people associate the bleeding with brushing. So if they stop brushing, they won't bleed, is what they think, and of course we know that isn't true. Also eating, and Alison sort of alluded to this earlier with her case study of the 24-year-old lady from Guatemala, but I've seen children come in with horrible mouth bleeds from eating crisps where they've scratched the roof of their mouth. And that's going to stop them from eating crisps ever again. But actually, we just need to be educating them around how to take care when they are eating, and to make sure that if they are bleeding because of gum disease rather than a crisp trauma, that they are being able to see the dentist to have better dental preventative care. And we need to communicate better between us and you, or you and us, whichever way that communication goes, via the patients and the parents. So that's a three-way group of people talking about what is the best way to treat people with von Willebrands disease disorder, and to make sure that they're getting the best oral care possible. So I tried really hard to find good evidence about dentistry and von Willebrands disease for this presentation, and I'm sure from the looks on your faces you're not surprised that there is lacking evidence. So I could find this one report by Watterson who showed that there's one RCT and one quasi-RCT, 59 people, men, with haemophilia. No trials when people with von Willebrands are identified, and they've actually put that in their paper, so it's not me saying that. Treatment guidelines are out there, but if you look at them, they're written mainly by haematologists. So it's all very well for me to say, yeah, just give 50 units per kilo of factor VIII for doing whatever it is that you're doing in their mouth, assuming that all dentistry, everything that you do, is the same. And I know perfectly well it isn't. So there is need still for more information and guidance for all of us. Roma has written this Implant Dentistry in Bleeding Disorders publication, which does discuss von Willebrand's disease and says basically you can do implant dentistry, so that's great. So that means that patients who have a bleeding disorder are not being excluded from having implant and restorative dentistry, which I know Luciana will talk about later. And there is a UK guideline for dentistry, which is quite old now, 2013, and it's for von Willebrand's disease. It just says treat like haemophilia. Well, it isn't haemophilia, it's not the same as haemophilia, and so we shouldn't be treating in the way that we do for haemophilia. So lots of room here for all of you to be going out there and doing some research and some publications. So the other treatments that we have are desmopressin, which some of you may have seen patients have. So this can either be intravenous or subcutaneous or intranasal, except at the moment that intranasal desmopressin is not commercially available. But that's a real shame, because actually that's a great product for people to have at home, and they can just have a sniff of it just before they come to the dentist, and they don't have to come into the hospital, so it can all be done at home. And that's ideally given 30 to 60 minutes before the procedure that you're going to do. Some people don't respond to it very well, so there has to be a test dose given at some point in their lives. And there's lots of side effects and risks if you give it repeatedly, so it's a great thing to give to people once or twice. And that's great for covering your dentistry. And then for everybody else, if we're not just giving them tranexamic acid and or DDAVP, we have to go down the factor concentrate route. So unlike in haemophilia, where there is recombinant factor VIII, constant factor IX concentrates, most of the treatment for von Willebrand's disease remains a plasma-derived product. There is one recombinant available. And the reason for that is that you don't want to just give the factor VIII to most people. You've got to give the von Willebrand factor as well as the factor VIII, and it's quite tricky to have a molecule that contains both, and some don't need both. They just need the von Willebrand factor, or they just need the factor VIII. So it's a little bit more complicated. This is where you need really good communication with the haemophilia team. And many of these patients are able, or most I would say, to self-infuse at home. And so again, that's no reason why they can't just come straight to you guys for dentistry. They can have a dose of factor before. If we know what you're doing and you've told us this is a bleed risk or not a bleed risk, we can make a treatment plan that's individualised to each person as they're having those treatments. So thinking about treating people with von Willebrand's, we as clinicians probably, or definitely, don't focus on the mouth enough. And what we need to do is to do that more. And what we need from you guys is really good preventative dentistry, so that they're not going to have the gingivitis and they're not going to have the mouth bleeds that they will then think is their von Willebrand's disease. That doesn't have to all be a specialist dentist. This can be the dentist in your community, but with referral to the specialist dentist if that is indicated. And that means including the person with the von Willebrand's, because they might have to travel to somewhere else to get treated. And to think about the social impact of living with all of that mouth and bleeding and blood, which is what Alison was just saying earlier. And here's another quote from another study that I'm going to talk about in a minute, which is a lady who said, I haven't actually been to the dentist for a very long time because I can't find one I can trust, because you make them bleed. So we have to get around that. It's not you making people bleed, it's not you that's causing them pain, that we need to work together to make their life better. So that was that bit. Any questions on that bit? Oh, we're waiting for Alison for questions. I'm now going to talk about, I've gone off the wearing my medic hat, I'm now going to wear the patient hat. So I'm now going to talk about oral health experience of people with bleeding disorders. So moving away from von Willebrand's disease, thinking more globally about people who have bleeding disorders. And I stole this slide from Alison. She doesn't know. So we were both at a women's bleeding meeting with the EHC earlier in the year. And one of the ladies was sitting at the back of the room with her face mask on, and this is a face mask. And she was sitting with her hand like this throughout most of the meeting, looking really uncomfortable. And at the end of the meeting, she left the room very quickly, and it transpired that throughout the whole of the meeting, she'd had a mouth bleed that had been just dribbling into her face mask. She was very distressed about it, and she said that even in a women's bleeding disorders meeting, that she felt very uncomfortable. She didn't want to tell people she was bleeding. She'd been having this kind of gum bleeding for a very long time. And as Alison said earlier, there was the whole thing around her perception of the smell from her mouth and the impact that was having on her intimate relationships. So thinking that this is just a bleeding disorder and it's a bit of mouth bleeding doesn't really pick up on the perceptions of the people who are impacted by it, and those psychological impacts are enormous. So I'm going to now focus on 3 recent studies which look at bleeding disorders across not just von Willebrands disease. So Cinderella was a study of women with bleeding disorders. Glanzmann's, and that's finished. Glanzmann's 360 is an ongoing study looking at living with Glanzmann's thrombocythemia. And the mouth is a gateway to the leaky body is an Alison study that has just been published, and we'll come back to that a little bit more in a minute. So Cinderella, you all know, she is in popular folklore a girl who didn't get recognised, was very obscure and neglected. And within the world of bleeding disorders, until about 4 or 5 years ago, this is where women were. So the whole of bleeding disorders care was about men with haemophilia, men with haemophilia, men with haemophilia. And then you might have a man with von Willebrands disease, but actually the women were all ignored. And the women with haemophilia, who might be historically called carriers, were also ignored unless they were pregnant and might be having another baby with haemophilia, in which case we all got very excited. And so all of that was an ignored bit of the work that we were doing. And we wanted to look at what it was like to be a woman with a bleeding disorder. So this methodology we've used in several studies. This is cross-sectional, non-interventional, mixed methods. So starting with a literature review and then a survey, so getting the quantitative data, and then in-depth interviews with patients with the conditions to get that real in-depth qualitative feedback from patients about what it is like to be them. And that really brings together the science from the literature review, the surveys, and then that real life experience of what it is like to be a person with a bleeding disorder. So this is Cinderella. So in this study, we had women with haemophilia stroke carriers. So some of the women themselves had a low enough level that they were considered to have haemophilia. Women with ITP, so an acquired bleeding disorder that happens later in life. And then women with other bleeding disorders, so von Willebrands disease or factor 13 deficiency, factor 7 deficiency, whatever. So you can see a good number of responses, 250 or more. And a really good age profile. So we've got women aged less than 16, so very young people. As you might expect, the majority through the sort of menstrual cycle years of 20 onwards. But also out here, some quite old ladies, and we don't ever hear from old people with bleeding disorders. So it's really good to hear from some older ladies who have lived their whole lives with bleeding disorders. And in the survey, we asked them where their bleeding symptoms were. And you might initially look at this and think, oh, look, it's periods and it's bruises. And that is true. But if you put together this one, bleeding after dental and gum and mouth bleeds, it's actually higher. So the amount of bleeding that these ladies were having from their mouths was huge. And yet still we don't recognise it and we don't treat it. And then in the interviews, we had 13 ladies who participated in either a focus group or an individual interview, and that was their choice. We had 7 with haemophilia, 3 with ITP, and 3 with other bleeding disorders, so 2 with von Willebrands and 1 with severe factor 7 deficiency. And the paper is published, but what I've gone back to is the data and pulled out everything that is around oral bleeding. And you can see here that they spoke about the difficulty of obtaining care and a lack of awareness and competence amongst the healthcare professionals altogether. So not just dentists, us as well. But quite a lot about, I had a specialist dentist at the hospital, but that stopped when I moved from children to adults. Nobody's bothered about my bleeding. I haven't been to the dentist for a long time because I can't trust one that isn't going to poke about and cause a bleed. So that's where we really need that good education, because yes, you're going to poke about, but actually you might cause a bit of bleeding, but the bleeding is there because of the von Willebrands and the gingivitis. We can treat the gingivitis and then the von Willebrands won't be the problem that causes them the bleeding. I couldn't stop bleeding. They just say, oh, it's an infection. They said to me, oh, that's just how it is sometimes, it's normal. Well, I don't think it is normal. If you go out on the street, it's not normal for people to be bleeding from their mouths. And there's this kind of understanding or assumption that we shouldn't complain about the fact that we've got all of these oral bleeding symptoms and how difficult that is to live with. So that's been published. We'll come back to that later. Ongoing at the moment is the Glanzmann's 360, which is looking at the life experience of people with Glanzmann's thrombosthenia, which is a very rare life-threatening platelet function disorder. So these are patients who will present with mouth bleeding, who have bleeding that is really difficult to treat. So they might bleed for 36, 48 hours before they even bother to come to the hospital, and then they might still be bleeding a week or two later. Obviously, during all of that, the bleeding is coming out. The blood is coming out of their mouths, they're getting anemic, we have problems with iron deficiency. Can be a really difficult disease to treat. There's only about 160 people in the UK. And this study, we're using exactly the same methodology as Cinderella. So we've got the survey and we've got the interviews. And as I said, it's ongoing and unpublished. But the early oral health data, and we haven't been picking on oral health particularly. This is a very chatty, tell us about your bleeding, tell us what's happening. So in 30 out of the planned 100 surveys completed and 6 out of 30 planned interviews, we've got people talking about visible bleeding, and that is predominantly from the mouth. It's a quote, I wake up in the morning and sort out my gum bleeding before I go to work. It's a 45-year-old lady who said that was her daily ritual. So she would lie in bed and think, is my bleeding good today, bad today? What do I need to do about it today? And then this is a man who said, I used to go to the dental hospital because of all the blood. It would be nice to go again because they give me complete reassurance. And that again was a service where he'd gone very much as a child and into early adulthood, but because of the lack of availability of ongoing care, he has now just going to a normal dentist and not to the specialist one in the dental hospital. So he doesn't have that reassurance and the feeling of understanding of his condition. More of that will come as we get more data, I'm sure. And then Alison's now back in the room, so she could come and do these slides. This is something that Alison has published in the last month. Yeah. It's a book chapter in Cultures of Oral Care, and it's called The Mouth as the Gateway to the Leaky Body. And here she and others looked at 60 people with haemophilia. 52 of those were men and 8 were women, and they were aged 20 to 80, and had in-depth interviews which were analysed thematically. Mouth bleeding came up a lot, as you would expect, and so these are some quotes from her paper. So your gums bleed, yeah, we all know that, and then you get that really bad taste of blood in your mouth, and we know what that's like. You know yourself, if you've been to the dentist and you've got a bit of a clot or something, you can feel it and it tastes horrible, it's that iron, but imagine that that's how your mouth tastes every single day. It's really horrible. And it feels warm, and you know it's there, you can taste it, and it's a clot, and it's going down your throat, and you're gagging, and it's the smell, and then maybe you vomit, and it's all those lumps of liver and jelly that you're spitting out. Really unpleasant. And as Alison said earlier, I was stuck to the pillow with congealed blood, and that's not normal, but actually when you talk to people with bleeding disorders, it is their normal. They talk often about waking up with blood all over their face for no trauma, no apparent reason, it just happens. I'm petrified of the dentist. That comes from my childhood, when every milk tooth came out was at least 3 weeks in hospital. They held down my brother to stitch his gums up to stop the bleeding, and there was no going back to the dentist for us all after that. So you can see how experiences way, way, way back in your childhood scare people. they don't then want to necessarily come to the dentist, and if they then associate coming to see you with more bleeding, they won't come back. So that's why it's really important, like Alison said earlier, to have that one-to-one relationship to talk about, yeah, you might have a bit more bleeding, but what we're trying to do is this, to stop the bleeding in 3 weeks, 6 months, whenever. It's really important. That's very individualised care. Respondents also reported altering their food choices in public, which Alison talked a little bit about earlier, and I had that little story of the little girl with the crisp earlier, but avoiding partner intimacy, which we've talked about already. And all of that is because they're frightened of bleeding from their mouth. And imagine that that must be fairly horrible to live with every single day. So the conclusions for this bit is that Cinderella has really shown that women get delayed diagnosis, and if they don't get a diagnosis, they don't get that good care, and that impacts on their oral bleeding. In Glanzmann's, we're getting this visible mouth bleeding is impacting on quality of life. People are still frightened of the dentist. And Alison's mouth as a gateway has shown that it's common to bleed from your mouth if you have a bleeding disorder, impacts on your life, and contributes to that fear of the dentist. So, what are we going to do about it? We've now got that evidence, 3 studies all saying the same thing, and you think, why is she talking about it again? Because she just told us that. That's new. 2-3 years ago, that wasn't out there at all. People wouldn't have been talking about it. So what are we going to do? We know there's that unmet need. So there's inequity in access to oral health care for people who bleed, so we need to change that. And to do that, we need to really raise awareness. So the EHC are trying to do that through patient engagement and patient advocacy, which is great. I'm not quite so sure that the bleeding disorders treating community is quite so on board with it yet. And for those of you now in the room might get suddenly 100 referrals next week, I apologise. But actually also, what are we going to do about it from, or are you going to do about it from the world of the dentist? So, alongside the EHC, there's another organisation called EHAD, which is the European Association for Haemophilia and Allied Disorders. And they have lots of working groups. And this working group, which has been together probably for about the last 5 years, just published a couple of years ago, about the 10 principles of care for women with bleeding disorders. So having done all bleeding disorders, this now goes back to women. And there are 10 principles, and I'm just going to show you in the next couple of slides a couple of them, 2 of them actually. So principle of care 1 is that there should be equitable access and quality of care for all individuals with bleeding disorders, irrespective of their gender. The writing on the right-hand side here in the black is what supports that principle of care in the words of the EHC and EHAD. So there's a lack of focus. We need to be better at recognising and diagnosing, that's us. And then we need to ensure access of care for women with specific and general bleeding symptoms. And they say, i.e. dental care. So they have recognised that women are not getting access to dental care in the same way that men are, and that needs appropriate multidisciplinary care, treatment and counselling. Principle 10, which is about involvement of women and girls in registries, clinical research and innovation. Again, the words on the right in black are supporting, apart from I've put in dental, because do you have a dental database? No. Do you collect any information about women with bleeding, or anybody with bleeding disorders, that we could be coming back to collect that information and to move forward in terms of improving the care that we're giving to all people with bleeding disorders, not just the women, as in this one? So you said no, that's a bit depressing. Something in your own hospital? No? 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 Okay, big work to do in dentistry then.
I've been trying for 15 years to get dental data in a core set of data from the WHO, from the World Federation of Haemophilia. I've tried to have it in the core sets, and I am pretty good at advocacy. And I have tried for 15 years to get it in the core set of outcomes. We have our own, we collect all of our data, but actually it's very difficult to get it in a core set. Because from my experience, the people who see the bleeds are the medical teams. So they need to collect the data, bleeding data, not us, because they go to there. So any help would be great. We all have our own dental data. I have a database, yeah.
Yeah.
23 years.
Yeah.
But we have been trying for 15 years, and before I retire, it's what I would like to see.
Another 20 years then.
Yeah, well, about another 5. I would love to see at least dental bleeding.
So I'm just thinking back into my own, experience. So we used to have written case notes, and you might say send to dentist, and the dentist would write something.
Yeah.
I don't think the dentist actually kept that as in a dental department. It was in the patient's notes. And now we have an electronic record, and they just would write in again, and there's nothing that joins it all up.
No.
It's just bits written here and there and everywhere.
I was going to wait till questions, but the key thing for us is that we don't have a suitable bleeding outcome measure for non-dental personnel.
Yeah.
So we are at the moment looking at validating a bleeding tool that non-dental personnel can manage. Bleeding that escapes from the corner of the mouth, bleeding which requires hospitalisation, so we can actually have an outcome tool and as soon as we have that validated, and we've got a study going on, we will roll that out and hopefully get that into a core set. But the real issue here has been that there isn't a tool, a bleeding tool, which is suitable for non-dentists.
Yep.
And it's those that see. So we're nearly there. So once the
Excellent.
tool is there, we can band together, and IADH can work with this to actually disseminate that. But I think that's the core problem. We have our own bleeding measures, but that's not what's needed
For here.
for this, because it's pointless us collecting our
Yeah.
stuff. We need you
Yep.
to be collecting our stuff. So we're nearly there, Kate.
Good.
The validation will be coming anyway. Sorry.
Good. No, that's fine. So I am on the last slide, which really just was to say that all of those experiences I've talked about, the ones that Alison's talked about, they're not just UK and Ireland. These are experiences of people across the whole. I've put here the EU, but globally. So, and if you think that Ireland and the UK probably has or used to have really good dental care, it was always free on the National Health Service. People could always access it. If we're still seeing this level of bleeding, then it must be worse in countries where there isn't any access to dental care. So we need to make sure that our oral healthcare provision changes to reflect the bleeding that we have in our patients and whoever is the right person to be assessing that. We need lots more preventative as well as therapeutic oral care for the whole bleeding disorder community. I don't think it's any longer acceptable to say, oh, mouth bleeds just happen. We wouldn't say joint bleeds happen in haemophilia, don't worry about it. We would do something about it. And that would improve those outcomes that Alison's just been talking about, which we need to measure, but also the quality of life for all of those people out there who are bleeding every day. So I will stop there. Thank you, Chairperson.
Shall we come and
Yeah.